This presentation introduces the concept of mechanical ventilation. So we'll explore how ventilators work with your patient and then introduce various types of ventilator settings. Now you should already be aware of the basic concepts of oxygenation versus ventilation as well as work of breathing, but let's get back to some of this physiology. Because mechanical ventilation is talking about breathing for someone in a sense, or having a machine ventilate someone's lungs, let's look back to how our lungs normally ventilate. Well, you probably recall that the diaphragm is a key part of normal ventilation. It contracts and relaxes to help us breathe. But why does this work again? Well, remember that as our diaphragm contracts, it flattens and lowers. So essentially we're creating a larger space in the intrathoracic cavity, and therefore this creates lower pressure or a vacuum so the air can rush into our lungs. When we exhale, the diaphragm relaxes back up, making that cavity smaller again and then forcing air out. So in a sense, normal breathing occurs with negative pressure or this vacuum created by our diaphragm. So if a patient needs support to breathe, if they need help and they need a mechanical ventilator, how do we mimic this normal negative pressure breathing? Well, back in 1932, the iron lung was created to do just that. Patients were placed in this large device to create negative pressure ventilation. However, negative pressure ventilation is no longer being used in modern ICUs. You can imagine a number of issues with this machinery and how there would be a number of barriers to providing care. So because we don't use the iron lung anymore, which mimics that negative pressure ventilation, we actually use positive pressure ventilation to breathe for our patients or mechanically ventilate them. So rather than our patients sucking air in, we're pushing that air in with a machine. So therefore, while normal physiological inhalation should cause negative pressure and decreased intrathoracic pressure, inhalation with a mechanical ventilator actually causes an increase in intrathoracic pressure. Now that's inhalation. So what about exhalation? Well, exhalation actually just happens passively where we let the diaphragm recoil and the pressure is released through a valve in the mechanical ventilator. So now that we understand that mechanical ventilators are going to use positive pressure ventilation instead of negative pressure, and they're pushing air into a patient, how does it do this? How is this machine set up to push air into a patient, or what we will call delivering a breath? Well, the machine can be programmed to deliver this breath to the patient in two general ways. It can deliver a set volume or a set amount of pressure. And this might sound confusing to you. It's just pushing air into the patient. What do you mean volume or pressure? Well, let's look at it this way. Here we have a water pump. And you may or may not have used one of these before, but essentially you push down on the lever to get water to pump out on the other side. Now, depending on how hard you push on that lever, you'll get different amounts of water. Let's say pushing with all of your might is 10 out of 10. And then just barely pushing down on the lever with your hand is a 1 out of 10. Now, the point of pushing down on the pump is to get water into your bucket or a volume of water. So if someone said, push as hard as you can, you will do just that. You'll push it a 10 out of 10, and you'll probably get a big amount of water on the other end of the pump. But that's not really what you were told to do. You were just told to push really hard. Now, what if instead somebody said, fill the bucket up exactly halfway? Now you're focusing more on the bucket. You still have to push down to get water, but you're not so focused on that 10 out of 10 or 8 out of 10. Instead, you're trying to push just as hard as you can to fill the bucket up exactly halfway. So either way, the bucket gets water in it. Either way, you're pushing on the lever on the pump. But one way, you're focused on how hard you're pushing on a scale of 1 to 10, and the other way, you're focused more on the bucket and how much water you got on the bucket. So let's look at you standing by the water pump as a mechanical ventilator. And then the bucket that's waiting to be filled up with water is your patient's lungs. So if you're focused on how hard you're pushing down on the lever, that's what we would call a pressure setting. So in this sense, the ventilator is being programmed to push at a certain effort or amount of pressure in order to get air into the patient's lungs. Now with a volume setting, Think about with the second scenario where you weren't so focused on how hard you were pushing, you were focused on the bucket and how much water was coming out of the pump. So this is how the ventilator sees volume. Yes, it still has to push. You still had to push down on the pump. The ventilator still has to push air out, but it's programmed to focus on the actual amount of air coming out and that set volume of air to deliver into the patient's lungs. So with both pressure and volume, the patient gets a breath. Just how with both pressure and volume with you and the pump, you still got water in the bucket. However, with pressure, we program the machine to push air into the patient's lungs at a certain set amount of pressure or effort. And with volume, we program it to deliver a specific amount of air. Now remember that logically there is still effort involved, but we kind of leave that decision up to the ventilator. How much effort or pressure is kind of up to the ventilator. So volume is the actual size of the breath, and pressure is the amount of effort put into delivering that breath. So let's think about what this means and how this might look in an actual ventilator. Now with volume targeted ventilation, the machine is programmed to deliver a set volume each time it gives the patient a breath. Now that volume is actually programmed in milliliters, and we call it a tidal volume, often written as VT on the ventilator. So take a normal breath. Not a big deep breath, just a regular breath. That's a tidal volume. The amount of air you just took into your lungs measured in milliliters is a tidal volume. So let's say we have a volume targeted ventilator with a programmed tidal volume of 500 milliliters. And it just so happens that the ventilator is going to give your patient 15 breaths a minute. So this would mean that this ventilator 15 times a minute will push exactly 500 milliliters into your patient's lungs. Now that's volume targeted ventilation, or a volume mode. Now when we talk about pressure targeted ventilation, we now program the ventilator to deliver a set amount of pressure, a certain amount of effort to push air into the patient's lungs. Now we can't just tell the machine push hard or push kind of hard. We actually have to give it a specific pressure measurement. And rather than using what you're used to describe like a blood pressure, for instance, which is our millimeters mercury, we actually use a different unit of measurement for pressure, which is centimeters of water. And this can take some getting used to, but think about how more water or deeper water would create more pressure and more weight than less or shallower water. So more centimeters water will equate to more pressure. So you might see a ventilator programmed to push 10 centimeters of water to deliver a breath. And this setting on the ventilator is called pressure support. Therefore, in this case, if we have a patient that is on a pressure targeted ventilator programmed at 10 centimeters water pressure support, and it just so happens that the ventilator is going to give your patient 15 breaths a minute, that means in this case that 15 times a minute, the ventilator will push that hard, that same force that 10 centimeters of water would produce, that same weight, the same amount of pressure, it will push that 15 times a minute to deliver those 15 breaths. Now, remember, we're talking about lungs, not buckets of water here. So we need to be thinking about what this amount of pressure or volume could be doing to our patient's lungs. We want to ventilate appropriately, but we don't want to cause so much stress on the alveoli that we cause damage. So how do we pick, volume or pressure? Well, put your mind at ease for now. That's not within the scope of this course. And as you will learn, when a patient's put on a ventilator, that comes with physician orders. And within those orders are whether the patient will be on a volume or a pressure mode. So now thinking about the differences between volume versus pressure regulated ventilation, what do you as the nurse need to think about depending on if your patient is on a volume or a pressure mode? Well, think about yourself at the water pump again. If you just push as hard as you can, what could happen to the water in your bucket? It could overflow. Now, you weren't really focused on the bucket, you were focused on the effort. So what if somebody said, okay, just push at a 5 out of 10 effort? So you follow directions and you only put in half of your effort, but it turns out this is an old, rusty, clogged pump. And when you only push 5 out of 10, you barely see any water come out the other side, but you did what you were told. And then what if someone else said, okay, now get the whole bucket full with one pump. And then let's say again you're working with an old, rusty water pump. you may have to push as hard as you can. You may even have to ask for help from somebody else to push as hard as they can to hit that volume goal. So you might already be thinking about how this would translate into a ventilator. With volume settings, the amount of pressure is going to vary to deliver that volume depending on your patient and their lungs. So for instance, if their lungs are full of fluid or maybe they have a lot of fibrotic tissue, the ventilator is going to have to push a lot harder to get that same volume into their lungs versus somebody who has great compliant lungs. Now with pressure settings, the amount of volume is going to vary depending on those patients' lungs and that patient. So if the pressure settings aren't enough for these tight or rigid lungs, then you may not get a very good volume of air into your patient. So bottom line, with volume settings, you would worry about the amount of pressure that's occurring to reach that volume. And with pressure settings, you're worried about if that amount of pressure is going to lead to an appropriate volume for your patient. So we've established that a ventilator will be programmed to deliver a set pressure or a set volume. Well, let's look at one of these intimidating ventilator screens. There's a lot of numbers here and waveforms and letters, and in the ICU sometimes these numbers are constantly changing and flickering and others are not changing. However, you can already identify a few familiar words and numbers here. So we talk about pressure versus volume modes. Can you see what mode this patient's ventilator is in? Pause the slide and then restart it to check your answer. So here you can see pressure under the title mode. Know that there will be a variety of different ventilator models and screens. So the point is not to memorize this one screen and where everything is on this one screen, but the point is to learn how to search for keywords so that you can make sense of what the ventilator is doing and what your patient is doing. Now, how is this pressure delivered? Pause the presentation again and see if you can find any familiar units of measurement and how much pressure this patient is getting. Here you can see 7 centimeters water under PC above PEEP, or pressure control above PEEP, that box. We now know that this patient is getting that much pressure, 7 centimeters of water, with each breath delivered by the ventilator. So as I mentioned, not all ventilators and ventilator screens look the same. Here we have a different model. See if you can figure out what type of mode this patient is in, pressure or volume. Pause the presentation and then restart to check your answer. So here again we see volume at the top of the screen. We also know that this patient is in a volume setting because of what else? Remember what each breath is called in the volume mode. It's a tidal volume, or VT. Can you spot the VT on this screen? So here it is. This patient is getting 600 milliliters of air, that volume, with each breath delivered by this volume mode ventilator. So any modern ventilator should have the capacity to be programmed into either a pressure mode or a volume mode. Now there's a lot more to a ventilator than just pressure or volume. For instance, how many breaths do we give the patient? And we say we're pushing air into them, but how much oxygen will be in that air? So to determine these types of details, we have what are called ventilator settings. And you already know 2 of these settings. The tidal volume setting is the amount of air, the volume of air in milliliters that will be delivered to the patient when they get a breath. And the pressure support setting, sometimes called PS or PSV or other similar names, that setting is the amount of pressure in centimeters water that will be delivered to the patient with each breath. So in the basic ventilator modes we'll be discussing in this course, you will only have one or the other. The physician has to choose. Will this patient be on a pressure or a volume mode? And then they begin to select settings. And if they've chosen a volume mode, then they will set a volume to a specific setting. So 500 milliliters tidal volume setting, 600 milliliters, 450 milliliters, etc. That's our volume setting. And the same concept applies if we've selected a pressure mode. So now it's time to select a pressure support setting. So will it be 10 centimeters water or 12 centimeters water or 8 centimeters water, etc. So now we'll be talking about the other settings that can be programmed into the ventilator. And these include FiO2, or fraction of inspired oxygen, respiratory rate, and positive end expiratory pressure, or PEEP. Now just note that there are many more settings that are included in a ventilator, but this is just your introduction to ventilators, so we're going to keep it fairly simple and also considering what the nurse is responsible for versus the respiratory therapist. So here are some details about the tidal volume setting. How does the physician decide how big that breath is going to be and what to set the tidal volume at? And how many milliliters per tidal volume will that patient get? So they use a calculation of 8 to 10 milliliters per kilogram of ideal body weight. Because notice, if we have an obese patient who is, let's say, 5'5", but they weigh 400 pounds, which is about 182 kilograms, that should not equate to a giant tidal volume of over, let's say, 1,800 milliliters per breath if we use that formula. A 5'5" person should not have that big of a tidal volume. So instead, we would calculate this off of a more ideal body weight, and the calculations for how to calculate an ideal body weight may vary per facility. But let's say we do maybe 140 or 150 pounds for this 5'5" patient, and that's roughly 65 kilos instead of 182 kilos. So now that 1,800 milliliter breath looks more like 550 to about 650 milliliters. Now looking at another different type of ventilator screen, can you find the tidal volume setting? Look for that VT. Pause the presentation and then restart to check your answer. So here you can see the setting for tidal volume is 460 milliliters every breath. You may have picked this one, 450 milliliters, or maybe this one, the 1450. But notice this very tiny little E after the VT and a very tiny little I after the VT there. These numbers are actually the ventilator telling you what the patient is doing. These are not settings. They're numbers to help us monitor our patient. And we'll get into these later. I know this can be a little overwhelming and a little confusing, but just remember you're looking for the VT, just the VT. And if you're looking at an actual ventilator screen, it's a little bit easier because you'll notice that the settings are the numbers that don't move or change. They're set. So again, these settings relate to the specific directions we give the ventilator about that specific category. So let's look at another setting. How about how much oxygen will be in the breath that we give our patient? This is called fraction of inspired oxygen, or FiO2. So let's explain this. Let's think about what you and I are breathing right now. We're breathing air. But within this air, there's a whole lot of stuff. There's nitrogen, there's some carbon dioxide, and there is some oxygen. But oxygen actually doesn't make up the majority of the air we breathe. It only makes up about 21%, depending a little bit on elevation and where you are. So our current FiO2, that fraction of inspired oxygen, is right about 21% right now. Now, our patients who are sick and need this ventilator for support will likely need a larger proportion of oxygen in the air that they breathe. So maybe 30% instead of 21%, maybe 40% or even 60%. So you can start to see a lower number means that our patient could be doing better. They don't need as much oxygen. They look more like you and I right now. And a higher number is a little more concerning. So if you walked into a patient's room with an FiO2 of 30%, and then you look next door and that patient is on an FiO2 setting of 90%, which patient do you think is having a harder time? It's the 90% patient that's having a harder time oxygenating. They need 90% of the air they breathe to have oxygen in order to oxygenate and perfuse. So now looking at this ventilator screen, where is the FiO2 setting for this patient? Pause the presentation and then restart to check your answer. So here it is. Now again, settings on a ventilator are the numbers that don't change. So if we were looking at this screen in real time, we would kind of start to stare at the screen for a second and look for that group of numbers that aren't changing and are not moving. And then identify within those where the FiO2 is. And on this model of a ventilator, it says O2 cons, or oxygen concentration. So you'll see a few different labels for FiO2 on different models of ventilators, but in general, this one's pretty easy to identify because it most likely has O2 somewhere in the label. So the next setting we'll discuss is respiratory rate, and this one's actually pretty easy to comprehend. As you can imagine, it's the number of breaths we program the machine to give our patient each minute. So a typical setting is anywhere from 12 to 20 breaths per minute, but this can really vary per patient. Maybe their ABG, their oxygen saturations, how much work the patient can do on their own, etc. All of those can impact what the respiratory rate will be set at. So this is going to show up on the ventilator as maybe R or RR. It may say RESP rate. It could have just an F or FREQ. And that F, or FREQ, stands for frequency, or the frequency of breaths per minute. So take a look at this screen and see if you can find the respiratory rate setting that has been programmed into this ventilator. Pause the presentation and restart to check your answer. So here you can see they used FREQ for frequency of breaths on this ventilator screen. So this patient is getting 12 breaths per minute. Now, before we move on, can you find the FiO2, or fraction of inspired oxygen, and the tidal volume for this patient? Pause the presentation again and then restart to check your answer. Here is your FiO2 of 70% and your tidal volume of 600 milliliters. So this patient is getting 12 breaths a minute, and each of those breaths is a volume of 600 milliliters, and each of those breaths is 70% oxygen. So while it may seem like we've covered everything in terms of settings, how many breaths per minute, the size of the breath, how much oxygen is in that breath, etc., there's still another setting we need to discuss in terms of how the patient is getting ventilated by the mechanical ventilator. And this is called PEEP, or positive end expiratory pressure. Now, in order to understand PEEP, we need to remind ourselves that our patients are not breathing normally, how they normally do physiologically. These patients are not using negative pressure ventilation, and we're not breathing with our mouths. We're breathing through a tube that's always there. So our patients are connected to a machine and have an artificial airway that's interfering with their normal anatomy and physiology. So by doing that, we're losing what's called residual volume. And this is something that occurs naturally in those of us that are not on a ventilator right now. Residual volume is actually describing the air pressure that's still in your lungs after you've exhaled. So each time you exhale, you're not fully deflating your lungs. Your epiglottis actually allows you to still have some air left over in your lungs to keep them inflated. Now, why is this a good thing? Well, if we did fully empty our lungs on every breath we exhaled, then we would have to re-inflate our lungs with every inhale. And this is hard. Think about having to blow up a completely empty balloon over and over and over. Your cheeks would get really tired. It's really hard. But what if there was just a little bit of air that was keeping the balloon inflated? Now, filling up that balloon and blowing up the balloon will be much easier each time. So our epiglottis creates this kind of mechanism in our lungs. We keep a little bit of air in there and hold that little bit of pressure so that each inhale is easier and our lungs aren't completely collapsing at the end of every breath, so we have to completely inflate them again with every inhale. Now, once we put our patients on a mechanical ventilator and put this artificial airway in, that disturbs how the epiglottis normally works, and we have to create this same phenomenon of residual volume artificially with this machine. We have to create some constant pressure to keep our lungs always a little bit inflated, just like that balloon, and that way all of the breaths delivered will work better. So in a sense, after exhaling, the machine needs to make sure that there's still some pressure in the lungs so that they don't collapse. And this is called positive end expiratory pressure, or PEEP. That positive pressure applied on the patient's lungs to keep them open after exhaling. So PEEP keeps our patient's lungs from collapsing. Now, sometimes it's easier to think of PEEP as this constant pressure that's keeping the patient's lungs open. But when we exhale, the PEEP, or positive end expiratory pressure, is the only pressure left over in the lungs to keep them open. And that's what that PEEP setting number is, that amount of pressure left over after an exhale to keep the lungs open. So this picture might give you an idea of how PEEP is important for our patient. So on the left, we have a patient who does not have enough PEEP or enough pressure in the alveoli to keep them open after the patient has exhaled. And on the right, we have a patient who has enough PEEP, and these alveoli are nice and inflated. Now, another thing to look at here, how close are the alveoli to the vasculature? So comparing the slide on the left to the slide on the right, PEEP is also important because it essentially pushes our alveoli closer to that ever so important blood supply to exchange gases. Remember, that's why we're breathing in the first place, is we need to communicate with the blood flow. The alveoli and the bloodstream need to have contact to exchange oxygen and carbon dioxide. So in looking at this ventilator screen, how much PEEP is this patient on? Pause the presentation and then restart to check your answer. Here you can see this patient is getting 11 centimeters water PEEP. Notice the amount of pressure. The units used is centimeters water. And that's keeping the patient's alveoli open. So a normal PEEP setting that you'll see on ventilators will be anywhere between 5 and 20 centimeters water. And you and I, not on ventilators right now, have this physiologic, naturally occurring PEEP, which is really our residual volume, of 3 to 5 centimeters water. So why would somebody need up to 20 centimeters water? Well, if there's some kind of pathology going on, some counter pressure, maybe fluid in the lungs, we have to push even harder to keep those alveoli open. Now, one important thing to remember about PEEP is how it can be used to enhance oxygen delivery. So remember how those alveoli in the previous slide were close to the vasculature when we had good PEEP? They were able to pick up carbon dioxide and deliver oxygen to the blood better. Well, when you have a patient who might not be doing well, let's say you have somebody who is having to have their FiO2 turned up. So we started at 30, but they're not doing well. We need to turn it up to 40. Oh, we had to turn it up to 50% and then 60%. Well, instead of just constantly turning up the FiO2, we can actually consider increasing the PEEP. So many times, once we get up to an FiO2 of 50% or more, we should start considering increases in the PEEP as well. So rather than just cranking up our FiO2 more and more and more, we need to consider other factors that could help our patient oxygenate better, like inflating those alveoli and keeping them open more. Now, as we talk about PEEP, it's important to recognize that there is also risk involved when we deliver too much PEEP. And really thinking about all of mechanical ventilation and everything we've been discussing, if we put too much stress on the lungs from this mechanical ventilator and too much stress on the alveoli, overloading the lungs by putting too much pressure on them or forcing too big of a volume of a breath into the lungs, that can cause what's called Volutrauma or Barotrauma. Now, Volutrauma refers to giving a patient with non-compliant lungs too big of a tidal volume or kind of overstretching them in a sense. And this can cause trauma to the alveoli, which can allow fluid to move into those alveolar spaces and where the air should be, not fluid. Now, barotrauma refers to giving too much pressure to a patient, and that can cause the lungs to become too distended and rupture the alveoli and cause trauma to the alveoli. And a high PEEP is a good example of how barotrauma could happen. So when these alveoli are ruptured, air can now leak out into the interstitial spaces, and severe cases of barotrauma can actually cause a lung to collapse or a pneumothorax. So barotrauma and volutrauma basically refer to putting too much stress on the lungs and causing trauma to the alveoli. So as the nurse, we need to keep this in mind when reviewing the ventilator settings. If that PEEP is too high or if that tidal volume is too big, we could be causing damage to the alveoli. So one thing that we'll be talking about later is called modes. Now, you've already heard me use that term mode when talking about volume versus pressure, right? So we talked about volume modes and pressure modes, and those are general terms in terms of how the ventilator will give the patient a breath. But there's actually more to a mode than that. A mode is essentially describing the general relationship between the ventilator and the patient. Whereas the settings we've been talking about, that FiO2, tidal volume, respiratory rate, etc., that gives us more details on the specifics of an existing relationship, an existing mode. So when I say relationship between the ventilator and the patient, I mean how much does the ventilator do for the patient in comparison to how much the patient will do on their own? So how is the ventilator interacting with the patient? Is it helping them a lot, helping them a little? For example, with this specific mode, will it allow them to take a breath whenever they want? Or will it determine exactly when the breaths will be timed? Will the ventilator allow the patient to take a breath and determine how big of a breath it will be? Or will the ventilator actually help the patient and increase the size of the breath? So that's the mode, this general relationship between the ventilator and the patient. And then settings are just the specifics describing what will happen once we're in a mode. So let's think of it another way. You have different ways of getting to work. Let's say you can drive a car and you get there in 15 minutes. You can take a bus, and that involves catching a bus and boarding the bus. You can take a train. Maybe you could ride a bike. You could even walk. So those are all modes in a sense, only modes of transportation, obviously. Now, the settings might be that you drive a Ford at 65 miles per hour or maybe a Mazda at 55 miles per hour. So they're both in the mode of driving a car, but the settings are different within that mode, depending on the type of car you drove. Or you could walk, but maybe one day you walked at 2 miles per hour with tennis shoes on, and the next day you wore flip-flops and you went 1 mile per hour. You still walked, that was still the mode, but the settings within that mode, those specific elements can change. So back to our ventilator, the mode is the larger category describing how the ventilator will interact with the patient, but the settings could be different within the same mode, just like the type of car you drove, the speed you drove, the kind of shoes you wore, etc. So that's the end of this presentation. In class, we will discuss specific modes by how the ventilator interacts with the patient. So for example, you see here a bunch of acronyms along the line. So as we move toward the word ventilator, that means the ventilator is responsible for more of the work. It's more in charge. And as we move toward the word patient, now the patient is responsible for doing more of the work. So be sure to review these modes in your text prior to our discussions in class.